I will just start by explaining who I am. I am Eloise Eddington, and I am CEO and founder of Fertility Help Hub. And for those of you who don't know, I have used my personal experience to create a fertility lifestyle portal to help people around the world find the content, resources and connections to people within the fertility world that I wish that my husband and I had had when we set out on our journey to have our children, where we use donor sperm due to my husband's infertility. So there's a weekly newsletter, expert content and a podcast, as well as giveaways and discounts, and it's the first of its kind. Now I would like to welcome Dr. Raul Olivares, who is Medical Director of Barcelona IVF. Welcome.
Thank you for inviting me. I'm very happy of taking part in this process. As you say, I'm a Medical Director of Barcelona IVF. But I've been dealing with infertility since the mid-90s, when every positive was like we were all clapping like crazy every time we had someone. Now we have managed to improve our results, though we are still far from what we would like to have. Barcelona IVF is a process that was launched 10 years ago, and we basically do everything and all kind of treatments. And one of the things that we love to do is to take part in these webinars to help and to keep patients posted about the last things that can be done and deal with their problems.
Brilliant. Thank you. Thank you for that introduction. And then welcoming the second panelist, Stefanie Valakas, who is a nutritionist and director of the Dietologist. Welcome, Stefanie.
Thanks for having me, Eloise. Really happy to be here. My name is Stefanie Valakas, as Eloise said, and I'm a fertility dietitian and nutritionist. I live and work in Sydney, but I am a digital practice, so I consult to women and couples around the world who are struggling to conceive. I have a particular interest in endometriosis, as I was diagnosed myself late last year. And my interest is really around helping women reduce their pain, improve bloating, and enhance their quality of life and their fertility, whether that be future or current, and using diet alongside other interventions to help support those goals.
Great. Thank you for that introduction. Right.
Pleasure.
So just a bit of housekeeping, some logistics. This virtual chat will last approximately 1 hour because they are very meaty topics that we're covering today. And it will be a conversation between our two presenters who you've just met, and a Q&A on endometriosis and fibroids. So thank you to everyone who has joined or watching this, who has submitted questions in advance. They were great questions. We will be recording this session so that people can watch back if they've missed it, and it will be going onto our Fertility Help Hub website soon. When you have a question, please click on the raised hand option, and there is also a chat box where you can speak to other participants. We won't be able to take questions from there due to moderating the webinar as we go, but if you want to talk to anyone, please feel free. And of course, you can remain anonymous with your video off. There is no need to say your name. So with that, let's start with our first topic of endometriosis. So I'm going to point this question to Dr. Olivares. How does endometriosis affect fertility, natural conception, and IUI and IVF?
There are basically 4 different ways in which endometriosis may impair the fertility. The most obvious probably is the fact that endometriosis may cause anatomical abnormalities, occluding the tubes and causing a tubal factor. Endometriosis can also affect ovulation. It may impair the ovulation. It may reduce the ovarian reserve, which is basically the main problem that we have when we treat these patients, that when we do IVF, it's really difficult to make them produce a good number of eggs. And one thing that is very important is that endometriosis, even the mild cases, may create kind of a toxic environment inside of the abdominal cavity that is the problem that, or is the factor that impairs the quality of the eggs. So the thing is that while the eggs are inside of the ovaries, they are of good quality. When they are released after ovulation and are exposed to the toxic environment that endometriosis causes, is when they get worse, and when the tubes pick them up to be fertilized by the sperm, they are not as good as before they were released. So anatomical abnormalities, ovulation alterations, this toxic environment, and reducing the ovarian reserve.
Okay, great. Thank you for that. I'm going to ask if anyone has a question to please say as we go through, so that we can ask your expert advice. And the same question to you, Stefanie, from a nutritional point of view. What are your thoughts?
Yeah, I think in my practice, the biggest focuses tend to be egg quality and any management of things like low AMH through any nutritional interventions. So that's really the big focus for us, is managing inflammation, also managing bowel symptoms, because that can lead to nutrient losses. So if you're having frequent loose bowel motions that are watery, we're losing lots of our nutrients, especially our B vitamins like folate. And so we really have to get on top of those to try and enhance nutrient absorption to support a pregnancy. So they're my key considerations around a woman who has endometriosis, who's actively trying to conceive. Obviously, I can't do anything on the anatomy front. I leave that all to the medical experts, but lifestyle can certainly have an impact on egg quality.
Great, thank you for that. And what about the different stages of endometriosis? Can a successful pregnancy occur with any stage, or at any stage?
Well, we now consider there are 4 stages of endometriosis, from mild to really severe, which is grade 4. The differences sometimes are the amount of endometriosis and where is located, the size of the cyst. If sometimes endometriosis can behave as a cancer, infiltrating, invasive, being very invasive of the different structures, bowel, bladder, okay? And in fact, yes, successful pregnancies can occur at any stage. The only things that are more unlikely, and as the endometriosis gets worse, so even in grade 4 endometriosis, I've seen every so often a natural pregnancy, okay? With regards to the treatments, basically the only problem that we have, and that is, as I've said before, is the ovarian reserve, because in the end, the more eggs we have, the higher the chances of the couple are going to be. So in cases of severe endometriosis, we are going to work with fewer eggs, and then the possibility of obtaining embryos is going to be not that high. In cases of mild or only patients who have problems with the tube and everything else with a good AMH, the pregnancy rates are really, really very good.
Okay, great. And when would it be necessary to have surgery for endometriosis?
Well, that's probably one of the most controversial issues, because nowadays the thing is, and I would say that this is what most of the clinicians think, is that surgery can only, with regards to fertility, and this is very important to remark, with regards to fertility, surgery can only make things worse. It's not going to help. There is no single study that has proved the surgery improves fertility. That said, there are people that need surgery because the pain is very heavy, the quality of life is really reduced, and then they need to do that. And then, of course, there is no other thing, because severe endometriosis responds not very well to the traditional painkillers and can be very, very severe. So I would suggest only surgery when there is the pain should be relieved. Okay. And of course, in those cases of minor endometriosis, or those laparoscopies that are done to confirm that there is endometriosis, I think that there is no point on doing that, because they are not going to change anyway the treatment approach, and they are not going to improve the outcome of the treatments.
And to that point, in terms of management, we're going to come on to that in a second. Well, we could talk about it now as it's come up, of course. And Stefanie, you know, having been affected yourself, it can be very, very painful. What are your thoughts in terms of management? And people have also asked in advance about whether there are any ways to manage pain with natural remedies rather than hardcore medication.
Yeah, absolutely. I think it can be really, as somebody with endometriosis and working with a lot of women with endometriosis, sometimes it can, I tend to see this trend towards trying to move away from medication, or trying to move away from conventional medicine in hopes of some kind of natural therapies. And I think, you can get the best of both worlds, and it's really a trial and error to find what works really well for you. For some, diet is a huge part of that picture, and for others, it's a smaller part of that picture, and that's okay. But diet can play a role in helping to manage pain and symptoms in the long term. Generally not speaking, in that moment, if you go and eat, that one thing, sometimes we do have those more instantaneous triggers, but not always. So the key things that I really focus on with my clients to help with managing endometriosis are foods that are rich in antioxidants, so colourful fruits and vegetables, herbs and spices, extra virgin olive oil. They're all very rich in antioxidants, and these can help fight free radicals, which can potentially help with managing things like egg quality, for example. Okay. As well as inflammation. So that's one strategy that I use with my clients, as well as trying to boost their omega-3 fatty acid intake. So getting those oily fish certs in, and or supplementation. If you're vegetarian, discuss supplementation with your healthcare professional, because vegetarian sources aren't well converted by the body, but they have a very potent anti-inflammatory effect and can help support blood flow as well, which is really important for both fertility and endometriosis. So they're just a couple of things that I do to help manage, and I tend to find the omega-3s is one of those ones that can have a really big relieving effect on women with endometriosis, and we've shown that with research as well. And we think that's because we're upregulating the synthesis of prostaglandin 2, which can help with relief of some of those contractions, both that can affect the bowel and also the uterus around the time of a menstrual cycle. So yeah, there's a couple of juicy diet tips in there.
And so what kind of foods would you favour to support pain management and the endometriosis as an issue?
Yeah, I have found that, generally speaking, a diet rich in fruit, vegetables that are colourful, oily fish, and then really beyond that, it gets really quite customized. I could tell one woman, say, hey, eat lots of whole grains, and she has IBS and quite sensitive to wheat, for example. Or, there's no research to suggest that we should eliminate dairy foods or soy foods, but at an individual level, if that's creating pain and symptoms, then that doesn't work for that person. And so the foundation I've always found is fruits and vegetables and oily fish seems to work well for everybody. But then from there, it gets like, I'm fine to eat, like, as somebody who has endometriosis, I've literally not changed my diet at all. And I'm fine. But I know many of the women I work with have a lot of food intolerances, and that's what we see in the literature as well, is that women with endometriosis report higher levels of food intolerances, and that is very idiosyncratic and unique to each person.
Absolutely. Thank you for that explanation.
Actually, just one thing.
Yes, please.
I really think that is very interesting, this kind of webinars, because sometimes the problem is that patients or either, tend to approach the problem from single side. Okay, so you go to the doctor, or you go to the nutrition, or you go to acupuncture or whatever. And I think that it is really needed to have a kind more of a holistic approach to this kind of treatments. And there must be communication between the different parts that take part in the process. I mean, what Stefanie is saying is great, but the time, for example, just giving an example, that 43 years woman can invest on these kind of things. I mean, it's going to be probably worse to invest 1 year trying to tweak your diet when you are 43, because what you are going to improve in endometriosis is going to be much worse in terms of the age. Okay,
absolutely.
So that's why I usually recommend on my patients to consider all aspects that can influence fertility, not just the treatment that I can do on myself, that if they think that acupuncture, but always taking into account every specific case. And taking into account all the different risk factors that patient may have.
Yeah, absolutely. I think as a young woman who hasn't, from my personal experience, that I'm not planning on having children any time in the very, very near future. But as soon as I got that diagnosis, it became front of my mind of what about my fertility? Now I have to worry about that. And so I see lots of women who are young, who are in their 20s, and they don't want children right now. And that probably leads into that fertility preservation question. And they're like, well, is there something I can do now to help enhance that? But obviously, there are so many factors that go into it. And it's not just nutrition, and it's not just medicine. Like you said, it's mental health, physical activity, different types of therapies work for different people. So we absolutely need to approach it from so many different angles.
Do you think things like acupuncture can help with pain management?
Yeah, absolutely, yes. I mean, sometimes the main problem with this kind of techniques is that people may want them to do something that cannot be done, So I'm not sure if acupuncture, because I have not seen any evidence that acupuncture may raise the ovarian reserve and the amount of follicles, that could be controversial. But there are many other factors that are important during the treatment. So we sometimes just focus on the final product, the baby, but how the patients live during this process and all different kind of things. For example, we recommend acupuncture before and after the transfer, because it may also help to keep the uterus relaxed. And there is some studies that have correlated the number of contractions that take place after the transfer with the implantation. Also, Stefanie was talking about these contractions and things like that, So I think that the only problem is when you just give just one approach and you want to treat. And I've seen patients that were 41 and they have been 3 years trying to be, and then when they come here, the only thing I can do, regardless of the endometriosis, is offering them egg donation, because they have lost the quality of the eggs. So that's really, really important. But we've done seminars talking about diet, osteopathy, acupuncture, and
That actually leads well onto the next question. Does endometriosis influence egg quality, and is egg freezing recommended in order to preserve fertility?
The evidence that we have right now is what I've said before. I think that while the egg is inside of the ovary, the endometriosis does not seem to affect the quality that much. There are studies that have done egg collections in patients who had endometriosis in just one ovary, and they were picking up eggs from the two ovaries, and they have compared what happens with the eggs that came from the ill ovary and the ones from the health. And they've got very similar fertilization rates, embryo quality, implantation rates, and things like that. The problem is that if you ovulate and the egg is exposed to that toxic environment, it's going to get worse. And here's where you can do a lot of things to try to reduce this environment, the severity of these environment. With regards to preserve fertility, well, yeah, it can be done, is one option. But I think that not any woman with endometriosis should consider fertility preservation. In fact, we work with the kind of it's called nomogram, which basically means they account different things, because we recommend this to those patients that may really have high chances of using the eggs in the future. So if you have a single cyst in one ovary, well, you may not even have problems to conceive naturally. So there is no point in considering fertility preservation. But if you've had surgery in one ovary, and then there is another cyst in the other ovary, and you're considering, because of the pain, that you need to go again through another surgery, well, then that would be an option, because 2 surgeries in 2 ovaries may reduce the ovarian reserve. And then, so it's basically to check which patients are likely to use these, to need, because so far the only big study that has been done has confirmed that the only like 10% of the people who preserve the eggs eventually use them. So in terms of specificity, is very poor. When you offer something that is only going to be necessary in 10% of the cases, it's like, as we say here in Spain, you're killing flies with cannons. And that's not what we want to do. We want to make sure that we recommend something that is invasive, that needs a surgery, when it's quite likely that you may need them, at least.
Great, that's really useful, thank you. I want to ask whether anyone has any questions at this point. Feel free to write in the chat box to other people who are here if you want to speak to them experiencing similar endometriosis or fibroid issues. And if you want to ask Stefanie or Dr. Olivares anything, then please raise your hand so that you can use this opportunity to get their advice. If we don't have any questions right now, let's move on to our second topic. Again, if you want to ask during this topic, please raise your hand. So, fibroids. Dr. Olivares, what are fibroids and what are the common causes?
Well, fibroids are probably the most common tumor. Are always, most of the time, are benign tumors, but is the most common tumor in women. Women around their 40s, probably more than half of them has some fibroids, but not all of them have an impact on the fertility. But that's the second question. I'm not going to answer it right now. Okay. The main reasons are that there are cells inside of the muscle of the uterus that start producing fibrin, which is a substance that eventually compacts, creating this impact. Fibroids are hormone dependent, okay, as endometriosis. So they basically tend to grow while there are estrogen, specifically estrogen activity in the body. And in this sense, we're now seeing that both endometriosis and fibroids are getting much more common. We see more of them. And we think that one of the main reasons can be substances that are present in the environment, in the food, called endocrine disruptors, that are chemical substances that work as if they were estrogens, okay? And there are hundreds of substances that have, or that we think that could have some estrogen effect that may increase the endometriosis and the fibroids. So it's also race dependent, it's ethnic dependent. For example, we see that black people tend to have much more fibroids, but probably twice the prevalence than white people. But basically, I would say that this kind of estrogen environment that is becoming much more common is the main reason of why they are increasing their incidence right now.
Right. Okay. Thank you. Can it be hereditary, both endometriosis and fibroids?
Probably part of them. I mean, I would say that this is kind of this kind of genetics that is called epigenetic. Okay, so you may have the basis to develop them, but what you do in your life is going to decide, is going to be the key to see if you eventually have it or not. Okay, so if you have a correct diet, if you do all kind of things, and your life is addressed in a way that you are not promoting the environment that may trigger the endometriosis, unless despite having a high risk, you are not going to. It's a bit like you may have some genes that may increase the risk of have a lung cancer. If you smoke, it's going to be much worse. So basically, it works a bit like that. So there could be cases which is straight away yes, but I think that the majority of the cases, it will depend on what you do during your life that is going to put that to let them show up or not.
So do you think lifestyle has something to do with it as well?
Absolutely, yes. Absolutely, yes. And this is a bit of what Stefanie was saying, no? I mean, if you are having endometriosis and you are 23 or 25, you are not considering to have babies in the short term, well, there are a lot of things that you can do to help to manage that condition. And probably with the fibroids, probably not with the same impact than that in endometriosis, you know. But yes, at least in terms of having it or being affected by them, you know. If you don't have a correct diet, if you are exposed to chemicals or things like that, probably the likelihood of ending up with fibroids is going to be much higher.
And the burning question, how can fibroids, or how do fibroids impact fertility and pregnancy?
Well, this is also a very, very, very difficult question. I mean, there is fibroids are different types of fibroids depending on where they are. Okay, if they are in the external wall of the uterus, they are called subserous, and these tend to have very little impact on fertility. Okay, they may cause problems because if fibroids tend to grow a lot during the first 3 months of pregnancy because the hormones are really high. They are, as I've said, hormone dependent, estrogen dependent. So if you have a big fibroid, it may grow during the first 3 months. It may cause pain, problems, even bowel occlusion, and you may need a surgery to remove that in a moment that is not the best moment to have that surgery. But the impact on infertility is not that high. Then we have the submucous, which are the ones that grow inside of the uterine cavity. And this is absolutely accepted that they impair fertility because they cause a pro-inflammatory state at the endometrium, reducing implantation rates. They may also affect implantation, increasing the risk of miscarriages. So these fibroids in 99% of cases should be removed, even if you are not looking for a pregnancy at that moment, because they may grow and they may make the surgery even worse in the future. Okay, and of course, before considering the treatment, these fibroids should be removed. And then we have the intramural ones, which are the ones who grow inside of the wall, and they are not subserous, they are not submucous. And then here is when we discuss a lot and we are not very sure. I would say that as long as the fibroids are not bigger than 5 centimeters, 2 inches roughly, probably it's going to be worse to consider the treatment and remove them than having the treatment, or at least surgically. Because once you go through a surgery, probably you are not going to be able to get pregnant after 6 months after the surgery. You know, we go back again to the time, depending on each case. If you are 42, investing 6 months to remove a fibroid that you are not sure if it's going to be a problem, probably it's not worth. If you are younger, you may decide, for example, if you are 42 and you are doing an egg donation, then no need to rush. Then it's better to remove the fibroid, let the uterus, because the pregnancy rates are going to be exactly at 42 than at 45 if you are doing egg donation. But if you are considering working with your eggs, no, the results are going to be different. So, as I say, I don't like standard approach to this kind of problems. Every woman is a world. Every uterus needs to be considered on itself, and also the other factors that are affecting infertility.
Thank you for that. And in terms of the different fibroids people can have, they can be in different positions, aren't they? So does that have an impact on whether there might be a disruption or an issue with natural conception versus IVF or IUI, for example?
As I've said, submucous fibroids should always be removed. There's no other option, you know. We have had for some years a medical treatment called ulipristal, which was really good on reducing the size of the fibroids without having to go through surgery. However, and unfortunately, this drug is now under revision because there have been described some cases of severe liver failure associated with this drug, and it's no longer available until we are sure that it's not going to cause any problem. But I've had cases of patients that have been on this drug for 6 months, that the fibroids that were 5-6 centimeters were like 1-2, and then we've gone on with the treatment and they have got pregnant. Unfortunately, we cannot offer this option right now. So the only thing is, or either if they have time, try to control the environment to reduce or to see if there is something that can reduce the size of the fibroids, or remove them surgically.
Great, thank you. And Stephanie, what would your suggestions be in terms of diet and management for fibroids nutritionally?
Yeah, I think Dr. Olivares really covered the point of xenoestrogens and foreign estrogens really well there, and plastic exposure, food wrapping, containers, water bottles, coffee cups. You know, when you think about it, our exposure to these things have never been higher. And there was a really interesting study that was done. It was a very small group of people, but they put a group of people on a very highly processed food diet for about 3 days. And they measured their urine for the BPA levels, which is one of the xenoestrogens. And then they switched them to a completely whole food diet for 3 days. And even within 3 days, they saw a 2/3 drop in the amount of BPA being excreted in their urine, which the body's trying to obviously get rid of the waste, right? But that just goes to show, you know, how much of an impact that diet is having on our levels of xenoestrogens potentially in our body. Obviously we can only measure what's leaving, but I thought that was a really it's a very powerful study to quote, I find, when working with people, because they're like, wow, that's just such a huge difference in just 3 days, 2/3. It's like, that's really tangible. So I think, you know, reviewing those things and reviewing them gradually, I think people can get really overwhelmed when you open up your, you know, your kitchen cabinet and you see how much plastic you've got in there. It can be really overwhelming and feel very expensive to go out and purchase, you know, glass or stainless steel everything, but just do it slowly and systematically, I think, and you know, tackle one area of your life at a time. Don't try and undo the bathroom and the kitchen and everything all at once, because you can feel really overwhelmed, and so can your bank account at the same time. So I try and encourage my clients to focus on the big players, which diet is the biggest, and then work from there. So that would be my top one. And then the other one would be reviewing where your body weight is at, because there is some association between carrying excess body fat and circulating estrogen levels. So they would be key factors to look at. Other studies have really looked at for fibroids more along the lines of increased risk of developing fibroids, so more like the preemptive. So things like alcohol intake, reducing that may help with estrogen production and reducing your risk of developing fibroids, and also not overdoing caffeine. So some research is showing that no more than 500 milligrams of caffeine per day, which is about really like on average 5 espresso shot type coffees a day, which is quite a bit, but I mean, if you're in Europe, that's kind of normal. So pulling back a little bit on caffeine and alcohol, reviewing your body weight, and really changing up your food exposure in terms of packaging and containers and things are going to be your low-hanging fruit in terms of having the maximum impact on things like estrogen especially.
In fact, how we cook can also may have an impact, because if the pans are too old and the Teflon is removed, the fact that you heat them is going to produce a lot of chemical substances that even if you buy healthy, but your pans are not the right ones, you may be losing all the benefits of that healthy.
I know. It always scares me when somebody tells me they're plastic food containers are flaking off. It just gives me heart palpitations. I'm like, no, get rid of them. Anything flaking, get rid of it.
What about the method of cooking, like whether you're frying or microwaving or baking in the oven? Do those kinds of things matter?
As far as I understand, no, not from a BPA perspective. However, you tend not to roast in plastic, for example, or fry in, well, Teflon is a perfect example, but I tend to find it's microwaving, takeaway containers, takeout containers and things like that. That tends to be the biggest thing, because people often don't pop it in a plate, and then, or they microwave with the cling film on or the Glad wrap on, and then you're getting plastic exposure that way. So I just tell, my clients, try to avoid heating up your food in a plastic container if you can. Either choose glass or decanter into a ceramic plate, and if you need to cover it, pop another plate on top to prevent the splash situation, and then microwave. Microwaving is fine, but it's actually the fact that it's the surface area is being exposed and then adding the heat on top that's going to increase that.
Mm-hmm. Catherine has just asked.
Not all the plastics can be heated. Some of
Yes.
them, exactly. There are, like, if I'm not wrong, there were like seven different types of plastic, and only 3 are those that are safe to keep food inside, or some of them are healthy to keep food as long as you don't heat the food inside of that plastic.
Catherine has just asked, what pans would you advise using to be safe?
Sorry?
Well, I think this is more to Stefanie, but
Sorry.
No, it's about food and cooking. What pans would you advise using to take precautions?
That's a good question. It's not actually a question I've ever got. What do you advise, Dr. Olivares?
Basically, what we recommend, because I reviewed them because I had a lecture about nutrition and fertility a few months ago. Basically, ceramic ones, glass ones, and try to avoid low quality Teflon, because the problem is that, and then you have to be very careful about what type of food you use. That's food that is much more demanding with the resistance of this Teflon. Avoid cutting or using the fork, because it makes small holes on the Teflon, and then it's much easier to release.
Anything with a coating was going to be my suggestion. Avoid anything with like a coating in the pan would be the best thing to do. But yeah, you have to be very careful with utensils as well, because a lot of the utensils we also use is plastic. So
the thing
wooden,
is,
and
Stefanie has said that it's much more expensive, because these kind of pans don't last as much as the others, and then you have to renew them more often. But as a long term, in a long term, they are absolutely safer than the old ones.
And do you feel the same way about products that people use on their bodies as well, in terms of toxins?
Well, I don't think that I mean, as long as the products do not contain, I mean, these kind of products tend to go through a bit more of strict controls, depending on what you buy on the product. But I wouldn't say that it's as dangerous as what you get eating or drinking.
Right, that's good to know. We've had a couple of questions come in. Apologies, they're actually going back to endometriosis. So I will read them out, and if you could both give your viewpoints, please, from both your perspectives, that would be great. Catherine has said that her next fresh IVF cycle is planned for August. She went through a failed frozen embryo transfer last year, following 2 cycles of egg batching. The clinic she is with now thinks that she may have endometriosis, as she has had very painful periods in the past. They've made her physically sick and a low AMH, but they advised me not to look into this further until after my next fresh cycle. If my next fresh cycle is not successful, would you advise I explore investigations into endometriosis further?
Well, I think that here there are two different things. In terms of fertility, no, because the fact that she has or she has not endometriosis is not going to change the approach. Unfortunately, she has not mentioned the age, which is something that. But in terms of quality of life, yes, that is when you may need to invest time on endometriosis, especially if there are very painful periods and things like that. But I really think that depending on the age, the fact that the clinic confirms or not that she has endometriosis is not going to change. She's doing egg batching, so that basically means that she has a really low ovarian reserve, and there is nothing we can do with endometriosis to improve this ovarian reserve. So the approach is going to be very similar in terms of fertility.
I think actually the second question may be from her too. It's anonymous, but it's similar. This lady has said she's 36 years old and she's been trying to conceive for 4 years. So is questioning whether to get endometriosis further investigated.
I mean, in terms of fertility, of assisted reproduction treatments, the recommendation when we have endometriosis, and basically because of that toxic environment that endometriosis may cause, is that when you have someone who has a fertility issue and you confirm that you have endometriosis, and regardless of the stage of the endometriosis, our current recommendation is consider IVF if you are doing something. So the fact that we confirm that she has a grade 1, grade 3 or whatever, as long as the anatomy is okay, because sometimes the problem is that endometriosis may cause something called hydrosalpinx, which is fluid inside of the tubes. And this fluid can be toxic because it can go back into the cavity and reduce the implantation, right? So as long as you do a scan and you see that everything is normal in the scan, having or not having endometriosis or checking or knowing the exact grade of endometriosis should not change the approach. You should consider IVF if you want to try any ART, and trying to get as many eggs as you can.
Great. Thank you very much for...
So just one thing, I remember that 15 years ago, laparoscopy was a routine test, was something that we were not doing IVF without doing a laparoscopy, which basically means inserting a tube inside of the womb of the abdominal cavity to see if there is something inside. We now know that in terms of fertility, this is not helping at all. And probably it is more close to 12 years that I've not done any single laparoscopy just to improve fertility. So, and this is how endometriosis was mainly diagnosed years ago, because was the only way in which we can see the small spots that sometimes are the only sign of the endometriosis. So I really think that I agree with the clinic that doing something that is not going to change the approach of that particular case should be avoided, because it's a waste of time and it only means putting a patient at risk during a surgery.
Great, thank you. I hope that's answered the question. Now, Stefanie and Dr. Olivares, is there anything else that you want to end with to summarize what we've talked about today?
Well, probably with regards with these two things, the fact that someone has endometriosis does not mean that it's going to be infertile, okay? Probably the only thing that I would change is the time that you need to spend trying to conceive naturally. As we always say, we consider that a couple needs to try for 1 year. If there is any risk factor, probably that should be shortened to 6 months before discussing your case with someone. And then, as I've said at the beginning as well, try to avoid single approach to a problem. Try to get a more holistic way, and based on each individual case, decide which is going to be the best approach for you. Not anyone needs to go to IVF straight away, especially if they are young. There could be other options, and you may want to invest some time on improving the conditions. it's true that we live in a society in which all people are stressed and all where people want to be pregnant tomorrow and not in 1 year, because when they come it's because they have also, but it's also our duty to inform and to offer them all the possibilities and consider different options.
Great, thank you. And what about you, Stefanie?
Yeah, absolutely. I think, you know, research is, and I know that more research is coming, but there is research to support that diet and nutrition can enhance the symptoms and quality of life of women with endometriosis. And we have data, and we certainly have some quantitative data, and there's always going to be, you know, imperfections in nutrition research, but we also have more importantly qualitative data, which is patients and their insights and what they believe is important for their treatment, and they're continuing to cite that they think that diet and nutrition is important in their own treatment of their conditions. And so I think it's starting to turn now, and I see it in my clinic that more and more women are coming to me proactively about endometriosis and their future fertility, as well as their current fertility, and enhancing their outcomes and looking at different perspectives and looking at different alternatives alongside their healthcare professional team. But it's so individual. I have such a spectrum of clients, from needing very, very little intervention to needing very specific, highly therapeutic type of dietary protocols to help enhance the management of their symptoms and quality of life whilst they're trying to conceive, not just as well to improve their fertility, but actually to enhance their quality of life whilst trying to conceive as well. So I think, you know, like Dr. Olivares said, they're different goals, but they're kind of not at the same time. So I think seek some individualized support around that if that's something that is really getting to you, and there is help and there is people that can help you. So absolutely reach out and get support.
Great, thank you for that. We've just had one more question come in just before we wrap up from Bridget. Now, excuse me, I can't pronounce these technical medical terms well, but asking, is open morcellation avoided in laparoscopic procedures?
Well, no, that's one of the surgical procedures that is done when the fibroids are really big. Because when you do laparoscopy, you basically make probably a 1 centimeter cut in the wall of the abdominal wall, and then sometimes you have to remove a big fibroid, you know, that is like 5 centimeters, and then you can sometimes doctors make another small cut to remove the fibroid, and there are other ones that prefer to morcellate. Basically means to slice the fibroid, and then you're cutting the fibroid, and then you can take it in small portions. Okay, so that depends on each case. It also depends on the expertise of each doctor, because here is a bit like in life, no, everyone has his own school and is used to work in a certain way. I wouldn't say that there is one specific that is better than the others. The individual approach, again, is probably the most important thing. And there are fibroids that can be morcellated and fibroids that should not be morcellated. So not really need to be avoided, but depends on each case.
I think she says she's at Fibroid Network, and they're looking into such issues and questioning progestin not being helpful for fibroids from recent research.
Well, the problem with the fibroid is that sometimes we don't know exactly what triggers the growing, and why they sometimes have a patient who has a really fibroid that becomes like 2 inches in 1 year, and then it stops there, and then it may also have kind of what we call caseous necrosis that gets really. So it's difficult to know. Doing some scans and seeing the pattern, the growing pattern of the fibroid is something that is also helpful to decide if it should be removed before it gets really big. But progestins and medical treatments probably are not other than the one I've mentioned, the ulipristal, have not proved to be really very helpful in managing fibroids. So this is why we now think that the only thing is to remove them or let them in.
Mm-hmm. Okay. And she's also questioning the Mirena IUD. Yeah, can you see the question there?
Yeah, I can see it, yeah. Exactly. No. Mirena is an intrauterine device that instead of the copper, which is the standard ones and metallic, has progesterone inside, and have been suggested that keeping the woman in kind of a pregnancy state, which with high levels of progesterone, may help to control, which is basically something that is recommended in endometriosis. Probably the best approach, the best medical approach for someone who has endometriosis and is not seeking for pregnancy is to use contraceptive that only contain progesterone. Because the best treatment for the endometriosis, the best is getting pregnant. Okay, pregnancy is the condition that usually helps to stop the evolution of endometriosis. With the fibroids, it's not that clear. So I would not suggest using progesterone. Okay, remember, Cochrane has confirmed this ulipristal is not recalcious, may need removal. Exactly. So depending on the kind of fibroids, the only thing that you can do is remove them.
Mm-hmm. In fact, she's actually gone on to say that she had twins without IVF after having 11 pounds of fibroids removed. So that's positive, isn't it?
Exactly.
Right. Well, thank you so much for your time today. Thank you everyone for joining. To answer some questions, yes, this has been recorded. It will be replayed. It will be on the Fertility Help Hub website. So please come back and watch it. I'm glad that everyone's found it useful. And thank you so much for your time today, everybody. And there are contact details here if you would like to chat to Stefanie or Dr. Olivares, then they would be welcome to take your questions and talk further.
Absolutely. Thank you so much, everyone, for joining us and for having me.
Thank you.
Okay, thanks, everyone. Bye-bye. Bye.